Okay, thank you, Wei, for the introduction and having me here. So today I will talk about cocktails of psychotropic drugs in an refractory mental health patient, and I use a collaborative approach to simplify her medication regimen. So my patient was admitted on October 2022. She's a woman in her mid-20s, and she was referred to a tertiary mental health center. Initially, she was started working as a medical office assistant, but during work, she became really stressed out, and she said that the auditory hallucination led to a serious suicide attempt with acetaminophen overdose, and which led to hospitalization. She came to us because her symptoms were refractory, her suicide attempts were recurrent. Her social history includes sexual abuse by close relative when she was a child. She does not use any illicit substances. However, she's in debt from inability to keep her job for more than 1 to 2 months. She had a lot of interpersonal relationship problems. In terms of adverse drug reaction, she had a history of prior drug-induced mania from escitalopram, citalopram, and venlafaxine. So her prior psychiatric diagnoses include schizoaffective disorder versus bipolar disorder for 10 years, anxiety disorder, borderline personality disorder, and she has had more than 15 prior serious suicide attempts involving either acetaminophen overdoses or self-cutting. Prior medical diagnoses include asthma, GERD, obesity, hypothyroidism, constipation, and she also had recurrent urinary retention, which is due to a tight bladder neck. And she has used catheterization and botulinum toxin injection to relax her bladder muscles. So here's the list of psychotropic drugs and medical drugs that she was on when she first came here in October 2022. As you can see here, she's on 5 regular schedule antipsychotic involving atypical and typical antipsychotics, plus a loxapine PRN, which she requests regularly to control her auditory hallucination. She's also on 3 mood stabilizer, the Lamotrigine, lithium, and topiramate. She is also on trazodone for insomnia and PRN lorazepam for anxiety. For her medical drugs, she's on bromocriptine, mometasone formoterol, levothyroxine, Pantaloc, polyethylene glycol, docusate, lactulose, sanoside, and benztropine, which she used regularly to manage her tremors, and some Tylenol PRN for back pain. And I want you to pay attention to the blue, the items circling blue, and think about how these medical drugs are associated with the psychotropic drugs. So when I met my patient, she has a lot of complaints. She told me that she felt really anxious. She feels sleepy during the day, but she had trouble sleeping at night. And there's a lot of voices in her head, and which leads to her suicidal thoughts. She also complained of constipation, have difficulty doing daily tasks, even opening yogurt container. She can do it, and she cannot write properly because her hands are too shaky. And she felt that her medication are not helping her, and she didn't want to take that many medication either. Because of all the complaints, I gave her a Glasgow antipsychotic side effect scale to assess the severity of her symptoms. It is a 22-item self-administered checklist which captures her viewpoint of her antipsychotic side effects. So based on this scale, she rated having issue with sexual problems really high, and every day she experienced sleepiness, increased heart rate, jerky muscle and shaky hands, symptoms of difficulty with movement, and also had no period for a couple months. Occasionally, she would have problem passing urine, have vision. Her vision was blurry, and she also has some uncontrollable movement of her body. In terms of mental status, I honestly didn't see any objective psychotic symptoms, and her thought form was organized and coherent. However, her mood was low and she was mildly anxious. Her vital signs were normal, complete blood count, liver enzyme, and her kidney function were all remarkable. The only thing that jumps out to me was her prolactin level, which is slightly elevated. And a level back in 2021 in April, it was 60.8, which is higher than the upper limit of normal of 26.7. And then her lithium level was 1.1 millimolar. Because she's on so many medication, I wanted to use an anticholinergic burden scale calculator, which can be found on this website. And what you can do is you punch in all the medication that she currently on and assess the severity of the cholinergic side effects. And I'm surprised to see that she actually got a score of 16. According to the scale, any score greater than 3 is associated with increased risk of falls, confusion, and mortality. And her score of 16, which means she is experienced a lot of anticholinergic side effects, which she already complained about, like her drowsiness, her stomach upset, her urinary retention, and blurred vision. And because of her tremors and difficulty with her movement, I also offer her a modified Simpson-Angus scale to assess the severity of her drug-induced Parkinsonism symptoms. This scale has 10 items, and each item can be rated on a scale from 0 to 4, with a higher score denoting a greater severity of Parkinsonism. When I asked her all this question, I combined all the score, and her score was 10. According to this scale, she actually fell into the clinically significant degree of movement disorder. So because of all these side effects, my initial concerns is patient feels that she's taking too many pills, but then none of them are helping. And her prominent side effects, including extrapyramidal symptoms, slow movement, jerkiness, and hand tremors. Her antimuscarinic symptoms, including constipation, difficulty passing urine, sleepiness, and brain fog. Her amenorrhea and her mild symptoms of lithium toxicity, which is her shakiness. It really bothers me, and I feel that the polypharmacy should be rationalized. Like being on 5 antipsychotic, 3 mood stabilizer, and an antidepressant doesn't really make any sense. And what is the rationale of having 5 dopamine antagonists, which are the antipsychotic, and an agonist, which is a bromocriptine? Are we using medication that counteract the effect of each other? And what is actually the evidence for her diagnosis? What are we trying to treat? And there's a lot of prescribing cascade in here. We're using benztropine for her Parkinson's symptoms, EPS, and then we're using multiple laxative for constipation. And what is bromocriptine? Does it contribute to her paranoia and auditory hallucinations? So at this point, we as a team felt that diagnostic clarification is really needed by our psychologists and psychiatrists. So our psychologist felt that it's really hard to differentiate her borderline symptoms from bipolar disorder. But that's why he took a lot of time to review all her visits to ER and other hospitalization to see the patterns of her remission. And for the past year, she had more than 10 ER visits due to self-harms, urinary retention, and chest pain. And whenever she was told by healthcare providers that her mental health has improved, she would overdose with acetaminophen and then she would seek help herself immediately. So without a psychologist's help, her diagnosis in November 2022 was actually borderline personality disorder with major depressive disorder, but she wasn't bipolar and not psychotic. So my simplest question is like, why is she on bromocriptine? So I asked my patient, and she said, it's for my pituitary tumor. I saw an endocrinologist in community for a high prolactin level back in April 2021, which is 60.8. And at that time, she was on risperidone 3 milligram, aripiprazole 20 milligram, and lithium 600 milligram. An MRI of the pituitary gland was done in July 2021, and they found that there's a tiny 2 times 2 millimole hypoenhancing foci in the left basal aspect of the posterior pituitary, which is suspicious for microadenoma. So what I did is I contacted endocrinologists who did this assessment and questioned about the pituitary tumor and what is the treatment plan. And the endocrinologist replied by saying, patient was last seen in March 2022, and I gave her a prescription for bromocriptine for 3 months. I didn't plan on prescribing any more treatment after that, and there is no follow-up planned. If the patient needs follow-up further, I suggest to see her to see another doctor. So at that point, psychiatrist, family doctor, and I all agree that she has taken bromocriptine longer than necessary, and we have to stop it. So we start to deprescribe her psychotropics end of October, and by the end of November 2022, her methyltrimethoprim was tapered and stopped. Risperidone was stopped. Aripiprazole was reduced from 30 milligram to 20 milligram a day. Lithium was reduced from 900 milligram a day to 300 milligram a day. And her clozapine was increased slightly to 50 milligram. Lamotrigine was increased slightly to 150 milligram. For her medical drugs, we also start slow deprescribing after we had rounds in December. Bromocriptine was stopped already in November, and propranolol was added for her anxiety. There are two reasons for ongoing efforts to deprescribe her medication. Because as of December 2023, with all these medications that were stopped, she still have side effects. She had recurrent urinary retention times 2 and led to ER visits in December. And that's why they did a cystoscopy and find that she does have a tight bladder neck. And in the end, the patient still need to restart the intermittent self-catheterizations for 3 weeks. And then she had a botulinum injection by her urologist to relax her bladder muscle in February 2023. And at that time, I did another lipid panels, and her cholesterol became more elevated. Another reason for deprescribing is also lack of efficacy of the current regimen. She still had a suicide attempt in January, despite being in our facility for 3 months. And then there is really weak evidence to support pharmacotherapy in borderline personality disorder. So by March 2023, her psychotropic drugs continue to be tapered off. Her aripiprazole was stopped. Trazodone was reduced and then stopped by end of March. Loxapine was reduced, and then she also ended up using less PRN. Her clozapine was slowly increased to 100 milligram per day, and the lamotrigine was kept at 150 milligram per day, and she continued her propranolol 10 milligram TID for anxiety. Medical medication was changed. In addition to the bromocriptine discontinuation, her benztropine and Docusay were stopped in February. And then her mometasone formoterol was also reduced from twice a day to once a day. And because the patient recognized that her shortness of breath was not really due to asthma, but more because of her anxiety. So I interviewed her in May after all the deprescribing, and she told me a few things. She said that being here taught her different coping strategies. Before, she thought that she was taking too many pills. She was feeling like a zombie in a constant haze. She didn't know that she can reduce any of them. Her mind feels now more clear and less foggy. And she said that doctor keep pushing her more and more pills, but now that she is more confident and would be able to stop more medication. She's still very scared of change. She doesn't like it, but she will adapt. And her goal is to be discharged to live in a group home with more freedom. So by June 2023, she's ready to go to a group home. And her psychotropic drugs was reduced from 10 to 6. She was on clozapine 100 milligram a day, lamotrigine 150 milligram per day, propranolol 30 milligram a day, PRN Ativan for her anxiety, loxapine 20 milligram a day plus as needed, but she's only needed 1 or 2 doses per day for her anxiety or voices. Fluoxetine 10 milligram a day was added in May, and it would be increased to 20 milligram a day by the time she was discharged, and is for the indication of major depression and anxiety. And there's no other changes to her medical medication. Unfortunately, back in July 2023, she was returned to our facility after 1 month, or maybe even less than 1 month stay in the group home, because she relapsed and she had a suicide attempt again. The reason why she came back is because she overdosed 2 times over there, and her mood swings, and she still have poor impulse control and poor scoping skill. She, like a little bit of trigger, if someone make a comment, she feel really triggered and didn't want to live anymore, and therefore she ended up killing herself. And then she also had severe constipation, which lead to ER visits. So when she came back, she was pretty much on the same types of psychotropic drugs, but her propranolol were stopped when she had bradycardia and low blood pressure after her acetaminophen overdose. So when she came back, a new psychiatrist felt that she was anxious, hypomanic, and paranoid, and very talkative. So initiated new changes. He stopped her fluoxetine, restarted the lithium, added buspirone, started haloperidol regularly, and clonazepam to manage her so-called manic symptoms and anxiety. So at that point, I was thinking, what do I do now when she's back? Honestly, for bipolar borderline disorder, the dialectal behavior therapy should be the main treatment, which is called a DBT. So our social worker encouraged her to restart the in-person and Zoom session weekly for DBT treatment. And after a couple of weeks, she was having good working progress on her self-reflection, and realized that when she overdosed again in August, she recognizes that it was her dad's comment about her not having a mental illness made her try to kill herself, because his comment invalidate her. But then in the past, she always said it was the voices that try to make her kill herself. So in this sense, like she's recognizing what the trigger was. And when we did multidisciplinary rounds in August, we decided to resume her fluoxetine to manage her anxiety, increase her lamotrigine, and then start melatonin to manage her insomnia, and resume the propranolol for anxiety, and then try to taper off the clonazepam, stop the lithium due to her history of urinary issues, stop the haloperidol because of history of EPS, and stop the buspirone, and trying to encourage her eventually taper off the clozapine, because it wasn't really helping. Initially, why we kept her on it is because patients said that it was helping for her suicidal thoughts. But now that she has done it again, we felt that it may be causing more side effect than benefit. And at that time, her prolactin has normalized, kind of at the higher, within like kind of normal limit, like 32. So in summary, I really want to thank this patient for sharing her story and the audience for interest. And there's a quote that she gave me I find really interesting, is she said that I didn't think I could stop any of the medication because none of them seem to work. I find that this is very ironic. And in summary, I really feel that we should stop a medication that hasn't been effective and stop it if it's causing more harm than benefit. And really need to avoid prescribing cascade, using one drug to treat another medication side effect. And really take your time to review your patient's histories, medication trials, and what is the patient's goals and desires. And very important, gather collateral information from other specialists and work collaboratively with other team members when you're dealing with complex patient cases. So this is a timeline to show you the things that will change over time, just for discussion purpose. Thank you.
Thanks so much, Angela. That's quite the case. 5 antipsychotics. That's a lot of antipsychotics. Okay, so we have a couple of questions in the chat. So the first question is about the assessment, and I'm interested to hear a little bit more about this as well. You use some scale, so anticholinergic burden scale, and also an antipsychotic side effect assessment scale. So the question is kind of how you integrate these scales into your practice. Do you do it before a medication is prescribed, or kind of as monitoring? So if you could give us a little bit of insight into how you use those tools in your practice, that would be great.
Yeah, I may not necessarily use them up front. Like, I only use it when the patient has complaints. Like, most of them patient, because they are refractory, they're already on a lot of medication, not like a fresh start on medication. So usually they would often come with some kind of side effects. When I assess them, when they've already tell me that they may be experiencing some type of anticholinergic side effects or Parkinsonism, then I would do these scales to assess the severity before I even consider what changes I would make, because you need to assess the benefit and risks for each patient, and each patient is different.
Yep. Okay, that's great. Thanks for that. Chris Rauscher has a question. Chris, do you want? You can just. I think we can just let you ask it. If you can unmute yourself.
Hi. Yes. My question's more about creating a strong team around someone who is so complex.
Mm-hmm.
And first off, could you just tell us where you're located and how you got involved?
Oh, yeah, I work in a tertiary mental health center because of patient confidentiality, I'm not able to really disclose where I work because I don't want people to identify her. But yeah, basically, if you really have a complex patient, I think need to refer to a higher tertiary level of care. That's basically what you need to do, because you cannot do it on your own.
Sure. Okay, so related to that, in your center, how was it that another psychiatrist came on board and didn't realize all the things you had done? And were you notified when that patient came in? I mean, I do geriatric medicine, and we really try and create strong teams with good communication and don't let that sort of situation happen.
Yeah, the communication is the key, because in a facility we have more than one psychiatrist, so it may not be the same psychiatrist taking care of the patient each time that they come back to the hospital. So we do communicate and tell each other what happened in the previous admission, and then because they may not have time to read through all the charts for these patients that are so refractory with so many pages of notes, and basically where the kind of the team comes into play, where because we worked with these patients in the past, the psychiatrist may not know, so I kind of give the feedback about what happened in the past.
This type of person really needs a lot of follow-up. Is that part of the practice where you are? Because so I'm not focusing on the medication. I'm focusing on how you can actually consistently try and have a care plan and address medications through that.
You mean like communicating from the discharge to the outpatient team? Yeah, we do the doctor do discharge summary and say what happened. in the past, like in the whole admission. So that is actually handed into the person that is receiving the patient. Yeah, that piece would be done, like the discharge
But in her
summary.
case, was there a community mental health team follow-up, you know?
She was discharged to a group home, and yeah, we did, like, it was only short, like it was only 3 weeks, and then I think they didn't even have enough time to really monitor her and closely monitor her, and then something already happened. And then I think the changes is also because she's very vulnerable with changes, so
Yeah.
that really trigger her. Maybe like a
Right. Okay.
slower discharge, maybe maybe that may have been more helpful, but it's hard in her case because she's not like a typical psychotic patient, but like more like a borderline, which in
Yeah.
general, borderline disorder, it's they don't recommend hospitalization. It's just because of the number of suicide attempts was so serious. It's just for mainly because of her safety that we keep her.
Okay. Yeah. I mean, I'm just trying to get the message that you really have to sometimes go the extra mile to make sure
Yeah,
the
it
team
does. Yeah, it
are
does.
there and the
Right.
follow-up. And you had
Yes.
to do it all the time in
Yeah.
geriatrics. Anyway, but thanks, Angela. It's very good.
Thanks, Chris. Thanks. Really great questions. We have a couple of other kind of interesting questions. I think we'll maybe do two more before we go on to the next case. And I think this is a really good question here about with so many changes happening, how do you disentangle potential withdrawal symptoms from like return of the actual underlying condition, because there seems to be multiple changes being made in kind of a short term period.
Which is it from the beginning, like from October to January?
So the question was just that there's the person's, on medications, then off medications. Medications are being stopped, and new medications are being added, and sometimes the intervals are kind of short. So I think it's just about disentangling like withdrawal symptoms from kind of return of an underlying kind of mental health condition.
We because she's hospitalized, so we monitor her closely. It's not something that really, like, if she were in the outpatient setting, maybe the process would be much slower. So that's why we have nurses like watching her every day. So if she does have if her sort of like her hallucination symptoms, whatever, came up worsen, then we will slow down the process. But we haven't seen any of that. So in the first, like from October to really February, March, we didn't see any increase so of her symptoms. That's why we felt that it was fine that we do this. And then there was some improvement with her constipation, and she does say that her confusion, her dizziness, and sleepiness were actually improved, and that's what I was seeing, because I'm seeing more the positive than the negative. So that's why we felt more confident in kind of reducing the other medication.
For sure. And then just kind of related to, again, medication changes, and this will be the final question. Obviously 5 antipsychotics, kind of like an evidence-free zone. How did you decide which medications to stop first? And then, so that's part A. And then part B is, I'm wondering, like, did you stop one at a time, or did you kind of stop multiple drugs at the same time? I'm talking about the kind of the psychotropic medications.
No, I kind of start with one at a time. After some medication were like in a lower dose, then we start tapering off the other one. So we kind of slowly doing over a few weeks for each drug. Yeah.
And how did you decide which to start first?
Oh yeah, yeah, because her EPS is really prominent. That's where I start first, and then I also focus on what her symptoms are. And because of the diagnosis is actually no psychosis, no bipolar. So really, it's really her symptoms, which is anxiety. So that's why I kept the I kind of added SSRI and kept the propranolol there. And like really, there is not much of a role of the other antipsychotic. And the patient did mention that the clozapine was helping her to reduce her suicidal thoughts, and the loxapine PRN was helping her, and that's why we kept that. I'm basically kind of led by her in this case because it's really, you
Absolutely.
need to ask the patient what they like to keep also.
Yeah.
And also sometimes psychoeducation is not just medication. You also have to work on your propane seal. But at that time, earlier on, she wasn't really interested in the DBT session. So I have to do something with the medication, but it's really mainly guided by her concerns. Yeah.
Yeah, no, that's a great approach. I think, yeah, letting symptoms and kind of preferences guide a lot of what you're doing. So that's really great. And I think, yeah, I mean, I think for me, what I took away from this is like you seem to do a really thorough job of assessment before you did anything. And I think that's really important. And as you said, close follow-up and monitoring seem to be, you know, also really important. So I think, yeah, really interesting case and a lot of kind of good practical tips coming out of there. So thanks so much for presenting. So we'll move on to the next case now. And so our next presenter is Trudy Huyghebaert, and she is a clinical pharmacist in the Department of Family Medicine teaching clinic at the University of Alberta in Calgary. And her interest is in chronic disease management and shared decision making.
Thanks so much for that introduction, Wade, and thank you, Therapeutics Initiative, for having me present this case. I have nothing to disclose, and I'm very excited to present this case. So our patient is a 68-year-old man, and he has a big list of chronic conditions. So interstitial pulmonary fibrosis, who requires continuous oxygen, COPD, diabetes type 2. He also has high cholesterol, obesity with a BMI of about 31. EGFR ranges anywhere from 49 to 60. He has hypertension, osteoporosis. He's been treated for about 10 years with oral bisphosphonate. He has, so he does use a wheelchair to get around. He has GERD. He had a fundalope application 16 years ago, and now does have recurrent symptoms. He has chronic constipation, depression. He has had suicidal ideations in the past. So healthcare providers involved in this patient's care, which I think really layers in the complexity. He has a respirologist, gastroenterologist, general surgeon, orthopedic surgeon, cardiologist, chronic pain specialist, family physician, and allied healthcare team. That's where we come in. And on that allied healthcare team, we have an RN, a dietitian, and myself. And then the patient also is involved with his community pharmacist. So in May, this is the medication list. So for hypertension, he was on amlodipine and irbesartan. For his cholesterol, he was on a high dose of rosuvastatin. He's on a PPI twice a day. For his insomnia, he uses trazodone, which works well for him. For his mood, he's on duloxetine and bupropion. For his chronic pain, he's on oxycodone long-acting, and he's taking it 4 times a day. He's on short-acting oxycodone. He's on pregabalin, diclofenac topical, cyclobenzaprine for muscle spasms, and then we had a short course of baclofen tried. He's also on acetaminophen regularly scheduled. For his pulmonary fibrosis, he is on nintedanib, which is a tyrosine kinase inhibitor, and he is monitored very closely through his respirologist with that, and they have a team monitoring that. He's also on tiotropium and olodaterone, or otherwise known as Inspiralto. For his diabetes, he's on empagliflozin, semaglutide, and he has significant nausea. He's being managed with Maxaran or metoclopramide and on Dancitron. And then for his diarrhea, and we'll get into that a little bit, he was put on Colestipol by his GI specialist. For his osteoporosis, he's on alendronate, calcium, vitamin D. And then for his iron deficient anemia, he's on ferrous fumarate once a day. Now I'll just we have a video to share.
All the conditions that I have, life sucks. There's so many drugs, I don't know what works, what doesn't work anymore. And I'm working with Trudy and Dr. Karim to try and figure all this out. I've got so much abdominal gas, abdominal cramps and pains, a mix between diarrhea and mush for months now. And I went for colonoscopy and couldn't go through with it because there was too much stuff backed up yet. But I'm on so many drugs right now that I can't anymore tell what's working, what's not working. And my quality of life, there isn't one. It's basically existing.
Over the last 4 weeks, and we made a few changes to your medications.
Some are working, some are not. I've gotten most of my appetite back. There's still some foods that taste off to me. I've gained a couple of pounds, which is I'm happy with. The changes are slow. Some have worked, some are not. We've made more changes today, and we go from there.
It's been really frustrating because Dave has so many issues going on. We're just hoping for a better outcome on the things we can change and the things that we may have some control over, and that would be huge in just giving us some joy in life again. You know, there's got to be a better way. Trudy's great. She's trying to help us the best that she can, and hopefully something works.
All right, so that video gets me every time. So what I heard from the video, sorry the sound didn't come out as loud as we wanted it to be, but we heard that he wants to reduce his medications. Not sure what is working and what's not. His most bothersome symptoms was diarrhea. And he's had bouts of fecal incontinence. He has a low appetite and a recent weight loss of about 70 pounds in the last 4 months. And that was one of his primary concerns of why he wanted us involved, is that he was having significant nausea. He's really concerned at this point. And also his quality of life. He feels like life is just taking pills. There was no joy at this time and not worth living. And so again, when we heard that, that was very powerful. So in May, some key physical findings: his vital signs on sitting, his blood pressure was 104/69 and a heart rate was 83. He did report feeling quite dizzy at times, especially if on standing. His O2 sats were 97. He was at rest and on 3 liters of O2. On physical exam, there was some generalized abdominal tenderness, but nothing that stood out. Laboratory values: his A1C was 6.1 and his EGFR was 49. All of his other labs were within normal range. So when we looked at the physical findings, plus talking to the patient, we went through every one of his meds systematically. And so we started with his diabetic meds. So he's complaining of diarrhea, loss of appetite, and weight loss. And then his most recent A1C was 6.1. So in that case, we felt he was over medicalized for his diabetes. So upon discussion with the patient, we said, why don't we stop the semaglutide and see if some of these symptoms correct themselves? He agreed, and it was stopped in May. So the GI meds, so his cholesterol, we asked him, do you think it's helping with the diarrhea? And he said he noticed no difference. So we said, well, why don't we stop it? And so we did stop it. There was some hesitation because it was put on by a specialist, but he was following up with the specialist in a couple of weeks after we'd stopped the medication. And we said, if you notice that it was helping, you can go back and start it again. When we did follow up, though, it was off. He didn't continue on with that. And then with chronic pain, so one of our working theories was that it wasn't actually diarrhea itself, but it was overflow diarrhea due from chronic constipation, and narcotics could be contributing in that case. So we asked him if he was willing to decrease his narcotic dose, and he was. So we went from 4 times a day for his long acting to 3 times a day. And so that was a 25% reduction. And at that time in follow-up, we asked him, are you ready to further reduce? But at that point, he said, I can stay at this dose, but I don't think I'm ready to reduce any further. So that's definitely something we're going to continue to work on together, but maybe more slowly. For his osteoporosis, we stopped his alendronate. He was on it for 10 years already. His most recent bone mineral density, his lowest T-score was -2.7, and he was assessed as a low fracture risk, a 10-year low fracture risk. So we stopped that medication as well. Back spasms. So we stopped the cyclobenzaprine and we thought maybe a trial of baclofen might help with his back spasm, but also help with chronic pain. After a trial of being on baclofen, he said it didn't help at all and he wanted to return to his cyclobenzaprine. So we did restart it. We restarted it at a lower dose. And so one of the big lessons that we learned with that one is that the patient's willing to trust us to stop some of the medications, but we also have to reciprocate that when the patient says, this isn't working, I'd like to go back to what I was on before. For his nausea, so we stopped the ondansetron, trialed metoclopramide, felt it was no different. But the exciting part about this is when we did interview him in August, we asked how his nausea was, and he said there was about a 40% improvement from stopping semaglutide, and he actually didn't need the ondansetron or the metoclopramide anymore. So that was really good news for us. For his mood, initially we wanted to reduce the duloxetine. We thought maybe it was contributing a bit to some of his GI side effects. And we did reduce it, but he felt strongly that his mood was worse at the lower dose, so he wanted to increase back up to 90, which we did. Cardiovascular wise, when we met him in May, he was hypotensive, so we stopped the amlodipine. We had reduced the arbesartan, and then along those lines, reevaluating his medication, he's on a statin for primary prevention, and so we thought, well, why don't we half that dose? You don't need to be on a high dose. His cholesterol levels were within normal range, so we went down to 20 milligrams a day for that. On follow-up in August, his blood pressure had increased to 112/79, and he did report less dizziness. There is still some room to evaluate. Maybe we should reduce that to arbesartan further or hold it and see what happens. Over-the-counter medication, so we reduced his iron to every other day. There is some good evidence to support better absorption with every other day. And then the calcium we reduced to daily, thinking that that might actually be contributing a bit to his constipation. Okay, so when we reevaluated his medication in August, 5 months later, we found that there was we reduced it from 26 meds down to 19 medications, and overall that over the course of the year, that would realize about a $6,400 annualized cost savings from those reductions. There. So our journey, we stopped 7 medications, so went from 26 to 19. We reduced the dose of 7 medications, 5 prescription and 2 over the counter. We resumed previous dose of medications in 2 cases, duloxetine and cyclobenzaprine, although it was also at reduced dose. And then we changed the capsule strength. So for some reason, he was prescribed pregabalin 50 milligram capsules, and he was taking 3 of them twice a day. And so when you look at the overall pill burden, we thought, well, it comes in 150, so let's do that. And it actually also realized a cost savings for the patient as well. And here's another video. Hopefully the sound is a little bit better. So again, Wade, if the sound isn't good, please let me know.
Well, we have been at this for about 5 months. And so we just wanted to hear what your thoughts are. One of the things you said when you came in, I don't know what's working, and I don't know what's not.
It's been very eye-opening. Being able to get off of a lot of the meds has helped tremendously. My outlook on life has changed, and it's good. Everything I'm taking now, I know why I'm taking it.
I'm seeing so much improvement. He's up and about again. This past weekend, we went camping with our daughter and her family. It was so enjoyable.
Yeah.
Just freedom.
It's out into nature. It takes away everything from in here, and I can just go brain dead, as they say, not think about anything.
And I think part of it, being able to do that, is thanks to Trudy and Dr. Karim and the Deprescribing, because he was on so much, and he still is. But as he said, now we have more insight as to what what's actually helping us and what was dragging us down. And it's a journey, but
It was worth taking.
it was a journey worth taking. Yeah. Many thanks to our fearless pharmacist and Dr. Karim.
It's a team effort.
It's a team effort.
Everybody had to be in it and do their thing.
Okay, so our lessons learned from this journey. First is in the planning. So take the time to review the patient's medications, discuss what their priorities are. And I think really what really helped in this case and for me was to ask if there's any preferences to stop or reduce, or are there any medications that they think are bothersome or not working? And then action. So make the changes. In this case, I think sometimes we might have made a few more changes than we would have because the patient was so motivated. A lot of times it's nice to just make one change at a time and do follow-up. But I think the most important thing here is to follow up closely with the patient and be prepared to restart. If you stop something and things are getting worse, then it's wise to go back, start again. And so with that too, if at first you don't succeed, try again. And then building trust is very important. I don't think I could have done this with this patient if I didn't have a long-term relationship with him. And he has been our patient for probably about 3 or 4 years. And so we've been working on and off together. And then he felt comfortable enough to approach us and say, I need some help. And then finally, quality of life. Ask your patient what brings them joy and work towards that. So in the initial interview, I should have said it initially, but the patient said, I said, well, what brings you joy, or what would you like to do? And he said, I just want to go camping. And this is back in May. So when he said he was able to go camping with his family, that really brought actually all of us a lot of joy. But it was really nice to see that we could get him there. And then lastly, to remember, taking pills does not equal improved quality of life in many cases. So how do we prioritize deprescribing with our patients? I mean, so in thinking about this, I thought, well, age, maybe the number of medications, maybe the number of medical conditions, multiple specialists involved, or when they ask. And I think really it's all of the above, and maybe priority is given when they ask. And another thing that this case brought up for me is I thought, well, maybe we should consider talking about deprescribing with the patient when we initiate a medication. So that preface of, we're going to start this to manage these symptoms or to do this. If it's not working, we're going to stop it and reassess. So the summary is still a work in progress. So the patient and his wife is motivated. We're going to continue to work on this. The nice part with them is they provide us honest feedback, with what's working and what's not, and that it takes time and constant reevaluation. And always review the advantages and disadvantages of medication, and don't fear stopping a medication that isn't working or is causing adverse drug reaction. And then remember to ask, what's the evidence? First of all, would this patient be included in the clinical trials? And what are the absolute benefits and absolute harms of this medication for your patient that's right in front of you? So my thank yous, the first thank yous to our patient for sharing his journey, so others can learn from this experience. His openness and vulnerability continues to be very inspiring. To Dr. Karim for always collaborating with the team and putting her patients first. And then, of course, UBC Therapeutics Initiative for allowing us to share these experiences and learn from each other in a really safe and collaborative environment. So thank you very much, everyone.
It was great. Very inspiring and tremendous progress. The videos really were just like very touching. I was smiling a lot at the end to see the how happy the person was to go camping again. So really nice example there. So we have a few questions, and I think one of the questions ties into something you just spoke about the process of initiating medications and maybe preventing people from being on so many medications, or at least being prepared for, a deprescribing conversation when the time comes. But the question is, how did this person end up on, long-acting opioids? I think also pregabalin and duloxetine. Like, was it multiple people involved in that, or kind of what was the journey there?
Yeah. So as with most of these cases, it takes a long time to build up to that drug. or those drug numbers to be on 26 medications. And so I think initially what happened with him, and I didn't talk too much about it, but he has severe left hip osteoarthritis that is actually eligible for surgery, but because of all of his other comorbidities, they're not going to provide surgery for him. So it just his pain kept getting worse and worse and worse, and tried other things. And then he actually came to us on narcotics. And so, as we know, it's a challenge to sort of peel that layer back slowly, but he's open to it. And especially in the fact that we sort of tied that constipation and bout like GI stasis with the narcotics, and he thought, yeah, you know, and then that 25% reduction didn't notice a big difference in pain control. So there's you're right, like there's just some more trust and buy-in to reduce it further.
Yeah, it seems like as you made changes, you got more buy-in, started feeling better, so then you can keep kind of making progress. So
and
it was really interesting.
Yeah, and I think the other thing, like I really learned from this one, is that especially the cyclobenzaprine, I was like, you have to be off that. I don't know why you're on that. And then I said, why don't we try baclofen? For sure it'll work. And then he comes back, he's like, it is not touching my spasm. So, and I thought, okay, you know what? Then for you, this is the right drug. So can we do a lower dose? So you're right. Like it's just moving sort of a step backwards and a step forward. So.
And just kind of tying into maybe kind of multiple physicians and involved potentially, like did you, in making changes, was it yourself and the family physician who were kind of initiating things, or did you consult with any kind of specialists or anything like that?
All of the above. So the nice part about the patient is he's very active. Him and his wife are very active in his care. And so he works really closely with his respirologist. And so even initially we thought, oh, maybe the nintedanib is causing a bit of that diarrhea. And so can we look into that? So he would have a follow-up. We'd say, okay, ask them about this. Can we do a dose reduction? And he would go ask them. Or Dr. Krim, I think we wrote a letter to the GI specialist just to say, you know, this is what we're seeing in clinic. This is our plan. Do you agree? And then so then when the patient had a follow-up appointment with them, they discussed it. And then we got that feedback back from the patient. So yeah, it worked really well.
Good communication with the care team and kind of making sure everyone's on the same page.
Yeah.
Awesome.
Yeah. And I think the big part, just when you mentioned that, I think the biggest part of that is that, remember, the patient is the quarterback of that team. And so if the patient has the knowledge and the awareness of why you're doing what you're doing, when they go to that specialist, then they can also present that, right? So, and they're really the center of our team. And so I think it really worked really well with this case because he's so motivated.
Yeah, but I mean, I think how you approach the case and how you kind of seems like work with both the patient and other specialists, and it's just really kind of like a very good example of how to kind of implement deprescribing in practice. Yeah, thanks again to the presenters, and thanks everyone for attending. Really happy to see so many people here.